Welcome. We still have some folks coming in from the back, so we'll let you get your seats as we move forward. My name's Janet Head. I am the chairperson of the Kirksville Campus Geriatrics Committee. I'd like to welcome you to our 6th annual Geriatrics Lecture on Aging. This has been a part of our geriatrics initiative since the board indicated that they wanted an initiative on aging in 2003. I do want to spend just a couple of minutes here recognizing the folks that we have with us today. First of all, I think we have some faculty from Truman State University in the audience. If they're here, will you all stand up? They may be caught out in the in-between transport as well. But we do have some representatives of state health offices and local health departments. Would you guys stand quickly? Okay. Welcome. As well as some local senior citizen organizations. We're planning on being here as well. So anyone from that group with us yet? All right. We do have members of the KCOM and School of Health Management faculty and administration who are in attendance, and I'd like for those folks to stand. We've got several down here in the front, honored guests or honored faculty here. Thank you. Back in the back. Thank you very much. And also our interdisciplinary house calls students, if you all would stand. Many of you, I think, know that we have an interdisciplinary program for KCOM students who visit elders in the community, and so we have several of those folks here as well. We have a number of KCOM students here. You were all promised lunch. Lunch will be handed out at the end of the presentation, so I'll give you a little bit more on that.
Got us
but we're glad you're here. Finally, I'd like to welcome the folks in Mesa. You can see on the screen back there the folks in Mesa, and they are led and organized and inspired by Elton Bordenave, who is the Geriatrics Committee Chair on the Mesa campus, and Dr. Jeff Alexander, who is a member of the faculty of the Health Sciences Department there. And so, hello, Mesa. We're glad that this is all working today. And there are a number of faculty and students there in Mesa from the School of Oral Health, the School of Medicine, and also the School of Health Sciences out there. So we're glad to welcome them. A couple of housekeeping things. There are sign-up sheets at the end of each of the rows. If you all would fill them out and then pass them. We do want to keep a record of who's here today. And then also, at the end of the session today, Dr. Willging will be leaving this room and going out into the lobby area in the Connell Technology Building. If you have questions, comments after the session, please feel free to catch him out there, and Dr. Creedon as well. And students, there will be the meat option sandwiches or the veggie option sandwiches back there as you leave the room. And there is a class in here afterwards, which means we need to make things ready for them as they come in at 1. As you can imagine, leading a program that covers 2 campuses in 2 states and a number of colleges is a real challenge. We have been blessed with having Dr. Michael Creedon, who is a professor of geriatric health management and is the chair of our geriatrics program here at ATSU to do that. And so I'm delighted to turn the program and the microphone over to Dr. Creedon.
I wanted to tell Janet that I really appreciate all the leadership work she has done in helping put this whole thing together. And to the committee members here in Kirksville, thank you for all the work. Both the faculty and student members of our campus committee on aging have done a lot of work, and we really appreciate it. Thank you, folks. I want to report to you that the campus and the university program on aging has just completed its first 5 years. And with the help of the campus chair in each campus, Janet here, and Professor Bordenave in Mesa, we have established a series of educational modules for use by all schools and departments on aging issues that are relevant to the student who is going to start working with older people in our society. And we hope to double the number of educational modules over the next few years that will be available for all faculty in all departments. We've also established very active outreach programs to the communities, particularly trying to get our students in both campuses into direct contact with older people in the community as they do their educational process, so that our students are already getting very direct experience of the lives of older people in our society and how healthcare can be provided to them. So we're very, very impressed with the house calls program here in our campus, and also a very, very strong falls prevention program that we've inaugurated with several communities in the Mesa and Phoenix area. And we're very proud of that outreach effort, and we hope to double that too. We've brought outstanding speakers to our university over the last 5 years through our annual lecture on aging. We've had faculty, senior faculty from Harvard, from Yale, from University of Texas, from WashU, and today a most distinguished member of the faculty, my friend Dr. Paul Willging from Johns Hopkins University, who also happens to be on the board of our university. And so we aim through this program to continue bringing to you top leadership people in the country in our field of aging, to bring their experience and their expertise to your attention. So in short, we are in the building process, and we want your participation, we want your help. We hope, if all goes well this summer, to announce the establishment of a Director of Aging Programs position on each campus. Hopefully Dr. Head will be the leader of in that position as we move towards it. So that will increase the amount of time available to provide leadership on each campus. And I think that will be a very significant step forward as we go into the future. I don't want to take any more time speaking about the program. I want to introduce our president, Dr. Magruder. And let me say that Dr. Magruder is unique in this community. He has successfully and vigorously led 2 universities in this town, and I got the honor a year ago now of being able to visit 2 glorious buildings that he built over at the Truman State University campus. And of course we ourselves are very honored that he led us through a very successful reaccreditation process during this past year, which is, I think, a fairly major achievement. Any university breathes a sigh of relief when the reaccreditation process is completed. So I want you all to give him a little clap and welcome him and thank him.
Thank you, Dr. Creedon. All those things he indicated were a result of the fine people that work around here and work at Truman. So, but thank you for your words there. It's truly a pleasure to have the honor of introducing this gentleman. Those who have served on the board recognize that he is an intelligent person. He asks a lot of questions, and he's extremely articulate. Now, in addition to that, I'm going to read some of this because I was so impressed in looking through this, and I cut about 2/3 of it away because I know about lunch. But I wanted to tell you, we kind of joke often because anything that comes up about any great university in the country, we try to not mention Johns Hopkins. But Dr. Willging does remind us about Johns Hopkins occasionally, and I can tell you he's had a long-term relationship with them in many different capacities. In addition to Johns Hopkins, though, he's had so many other things going. He's been the president of Assisted Living Federation of America, served as the president and chief executive officer, and this involved 40,000 assisted living facilities. He's also worked in the School of Graduate Business School at Johns Hopkins, as well as the Senior Housing and Care Program. Several things at Johns Hopkins. He's also done something great at another great university, A.T. Still University, and Dr. Creedon mentioned that. He has served with Blue Cross Blue Shield of Greater New York and managed a staff of 400 service representatives responding to 4 million calls a year. He's been an administrator with the Department of Health and Human Services in Washington, D.C. He has served in many positions. In addition to that, I'll mention his schooling, which you already know about. It's in the bulletin, but a Ph.D. and master's degree from Columbia University in New York, but a bachelor's degree, magna cum laude, in German literature from the University of St. Thomas, St. Paul's. He's also had awards and connections with many different states, Colorado Health Association, Virginia Bar. He was a Distinguished Service Award winner with the Department of Health, Education, and Welfare, Columbia University Faculty Fellowship, Ford Foundation Faculty Fellowship, Woodrow Wilson Fellowship, and a Fulbright Scholarship in Berlin. So this gentleman has been around the block. He's extremely capable and competent, and he's given a lot of time and devotion to A.T. Still, serving on our board in a wonderful way. There's a whole lot more. He's had connections with University of Kentucky, University of Maryland, University of South Carolina, George Washington University, and other places. And I know about lunch, so I'm going to end it, but I just like to say we're welcoming my boss, our friend, Dr. Paul Willging. We're delighted you're here.
Thank you, Jack. He's been around the block. I think that's a euphemism for he's old. And obviously has had great trouble keeping a job over the years. That's about all I got out of that introduction. Thank you very much. I appreciate it. This is, for me at least, coming home. One of the most enjoyable experiences I've had over the course of a number of years of career activity has been being involved with A.T. Still University before it was A.T. Still University. I began with the School of Health Management, which was a part of the College of Osteopathic Medicine here in Kirksville, and only subsequently did we in fact change the name and our mission. I was actually the first program director of the Masters of Geriatric Health in the School of Health Management. And from that point forward, I think my life and that of this university have been inextricably intertwined because I discovered very early that a key to the effective management of geriatric services, and when I use the term geriatric, I'm not talking about medical services, I'm talking about the entire wealth of experiences that are particularly important for the elderly. When you're talking about geriatric services, if you get to know the field of osteopathy, you see immediately that relationship between the two. I work at a university, I'm in the medical school at Johns Hopkins University, a bunch of allopaths, one or two osteopaths when we're lucky enough to get them. But I have spent so much time in the field of geriatric services that I understand the difference between your, I don't want to say run-of-the-mill, but your more typical, more middle-aged patient and your geriatric patient. American medicine, and we'll talk a little bit about that today, doesn't yet fully understand this concept you have heard about day in and day out of mind, body, spirit. Is that not one of the benchmarks of osteopathic medicine? And what better approach to dealing with the multiple needs, not just the medical needs, the multiple needs of the geriatric patient, than to understand that you have got to focus on mind, on body, and on spirit. This has been my life. I enjoy it. I've been told the system is foolproof. It now is going to get its real test, Janet. Aha. Why have I been so enthralled with the field of aging? Why I hope by the time we're done you will be, despite me, enthralled with the field of aging? Well, one, it's the inevitable personal experience. Show of hands, how many of you have either in family or as an acquaintance somebody above the age of 70, 75? Above the age of 80, 85? How many of you, showing hands now, have seen that increasing frailty, that increasing dependence, that increasing need for support? I mean, we all are going to have, or most of us, that personal experience. We have the inevitable political experience. How many of you know, because we hear this every year, that Medicare is going bankrupt? Heard that one? The only thing that changes, is it going to be next year? Do we have 2 more years? Do we have maybe 5 years? We have a demographic wave in this country. In fact, one of my previous bosses called it the Silver Tsunami, which about as reflective as you can get. The Silver Tsunami. I read an article by a colleague at Columbia University in the School of Public Health who says, in fact, it's going to be even worse. That the projections in terms of the numbers of elderly Americans 20, 30, 40 years down the pike could be off by a small number. It is a small number, 1% to 2%. Do you have any idea in terms of unanticipated expenditures through Social Security and Medicare what a mere 1% to 2% will do? You add a few million, and I think it did something like 4 to 7 million additional Americans over the age of 65 than we currently anticipate. Okay, 4 to 6 million. Now, when I took the SATs, in verbal, I got a 99th percentile, okay? Which means simply I'm glib, or I like to talk, or people think I'm glib and like to talk. In quantitative, I got a 20th percentile. So this is going to be tough for me to multiply $10,000 per Medicare patient times 7 million additional Medicare patients we hadn't anticipated. Anyone know what that comes out to? I think it's a big number. Or take the $15,000 to $20,000 per Social Security recipient. Multiply that by these 7 million additional people that have not been in the projections. Another big number. And this is not just pie in the sky. These are 2 very, very astute gentlemen who wrote this article. It came out just about 5 or 6 months ago, who say that the projections we have to date, which are run largely by the Census Bureau and the Actuary's Office at the Social Security Administration, have failed to take into consideration advances in technology. They hope they're wrong. You should hope they're wrong. Because we know one thing about our Congress, don't we? What is the primary purpose of any congressperson? And anyone who says to do the public good can leave this room right now. It's to get reelected, isn't it? Does that mean grappling with major societal issues or avoiding major societal issues? So at some point, when nobody can write a check because there ain't no money left, we might in fact find Congress willing to deal with this issue, driven by the demographics, and we've talked a little bit about that. This is, I believe, my friends in biostat tell me that this is what is called a geometric curve. In other words, it's not linear. This is the number of Americans over the age of 85 and the growth they are going to experience over the next few years. The American population as a whole is going to grow between now and, say, the year 2030, 2040 by around 35%. The American population over the age of 85 is going to grow by, anyone want to venture a guess? 400%. Why is that a problem? What percentage of Americans over the age of 85 are already consuming great quantities of health care? 22% are in nursing homes today, not subject to a nursing home visit, in a nursing home. Anyone want to venture a guess as to what the average annual cost of a nursing home is? $75,000 per year. Anyone want to venture a guess as to what percentage of nursing home residents have their bills paid for by Medicaid? 66%. By Medicare? Another 10%. By the Veterans Administration? another 5%. Basically, that industry is, in fact, a government-financed industry, and the more seniors we have, the more costly it's going to get. This is also, for me at least, one of the most fascinating. So, wait a minute, there's something I can push here. Bear with me. Ah, look at that. See that little red dot?
Yes.
Okay, I barely can, but I'm a senior, I've got excuses. By the year 2050, 1 out of every 20 Americans will be a senior. We have today more seniors than we have school-age children in this country. By the year 2050, the number of seniors 85 years of age and above, that's the 1 out of 20. 1 out of 5 Americans will be seniors, that is over the age of 65. 1 out of 20, that 4.8% up there. That's the number of seniors in terms of their percentage of the American population. That's a lot of people. That is a lot of people. Why is that insignificant? Well, obviously, we've seen a dramatic increase in life expectancy since 1900, when the average age of an American was 50 years of age. Now it's closer to 75, 85. Interestingly enough, that sounds great, but where did that incredible growth in life expectancy come from? It didn't actually come from our ability to do a better job of treating seniors. It came from our ability to do a better job of treating newborns, inoculations, immunizations, that sort of thing. So if you were 70, you really only were going to get 3 more years added to your life expectancy. And in the meantime, we were keeping you alive, but we weren't really making you much healthier. We've been less successful in treating chronic disease than we have been in dealing with some of the other disease types that are important to seniors. And the end result is a question: we may be getting older. Are we really getting healthier? Now here I've got to pause and define health broadly as well. When I talk geriatrics, I'm talking about the entire array of services that seniors rely on. When I'm talking health, I'm talking not just the more traditional definition of health, medical health, but health including quality of life. And what for most seniors is the most important element in their lives. And guess what, folks? It ain't health as we understand it, it's independence. If you ask seniors, and we have done a lot of polling, if you ask seniors what's the most important thing in their lives, it's the ability to maintain independence and to maintain the lifestyles they become used to. In other words, quality of life. And as you get older, that becomes more problematic because of the advent of chronic conditions. You know, when we all died at the age of 50, we didn't worry much about chronic conditions. How many of you have heard Crossing the Quality Chasm, the major treatise produced by the Institute on Medicine, how many years ago now, Phil? 15? Is it? Most of healthcare in this country is now chronic disease. Not the organ that goes bad, not the hip replacement. It is chronic disease. It is diabetes. It is Alzheimer's. It is cancers. The lingering stuff that you're going to have for the rest of your life. That is, I think, reflected well in this slide. And something related, but not the same. You know, having an ADL, that is an activity of daily living dependency, that's not the same as disease, but it is a part of getting old. ADLs are those basic functions each of us have to perform every day. That's why they call them activities of daily living. There's a big debate that goes on in gerontology. Are there 5 or are there 6? Michael, how many do you think there are?
I think we were talking about 7.
Mike is getting a little older, okay? Those of us at reputable universities consider it. Well, you know what makes Johns Hopkins reputable? Because that great peer-reviewed journal, U.S. News and World Report, says we're reputable. How dare you criticize the U.S. News and World Report? Unless we talk about the best rural universities in the country in health sciences, in which case we think the U.S. News and World Report is okay because they rank 18 still way up there. Activities of daily living, I think there are 5, but it is basic. These are the activities of daily living. Getting up in the morning, washing or bathing, eating, dressing, ambulating. You gotta do those 5 things every day. And as you get older, your chances of being able to do them unaided, that is, your chances of becoming dependent, dramatically increase. I hate to bring disheartening news to this young and vibrant audience, but look to your left and look to your right. Those stairs are going to get increasingly difficult to climb. Frailty, which is not disease, frailty is a natural part of the aging process. It has implications for the healthcare delivery system, which is, if there is one message I'd like you to take from this session, it is that one has to deal with the totality of a geriatric patient's needs, not just the medical. And I'm speaking to the future docs here as well. You will become good geriatricians when you understand that, when you apply in your day-to-day practice the concept of mind, body, spirit. You will make the best medical directors in long-term care institutions. You will make the best medical directors of adult daycare, of home care programs. So the hallmark of aging is, in fact, vulnerability, frailness. The growth of the elderly is exponential. Society may or may not be prepared to deal with that. Show of hands. Is the United States ready to confront the Silver Tsunami, or are we essentially an ageist society? Those who would argue we are ready, embarrass yourselves by raising your hands. Those who think we have a ways to go, raise your hands. It's unanimous, folks. We have a ways to go. And the consequences for healthcare are indeed quite dramatic, because the healthcare system today is not prepared to deal with the geriatric patient. There are 4 components of good care for the elderly. Medical management is only one of them. But medical management is the one that most permeates the healthcare delivery system for seniors. Mental treatment is equally important. Incidents of alcoholism, incidents of depression are disproportionately higher among seniors than they are in the general population. Social well-being. What's that have to do with health? Well, take care of a few seniors and you'll know what social well-being has to do with health. It can lead, if you do not have those social ties, to depression. That depression can in turn lead to all sorts of more purely medical issues and psychology. I hate to say it, because I hate to give credit to any kind of a government entity. But even though I did run what is now called CMS for a number of years, that was when it was well run, by the way. I mean, I don't know what happened when I left, disaster. And I'm sorry, well, no, we don't have an administrator of CMS yet, but one has been announced. And if I do too much of this meandering off track, I'll never get back to what I really wanted to say. What did I want to say? Can you remember? We'll go to the next slide, that'll tell me. What we need to do is recognize that all of these parts of healthcare come together. And they include things that normally you wouldn't think of. Normally you wouldn't think of. How many docs, I'm not trying to be snide here, but how many docs when they're treating a patient, and I'm not talking about the geriatric patient now, I'm talking about the regular patient, worries about what the house looks like that you're going to send the patient home to, or whether the patient even has transportation. We figure the patient got to me today, must have a way to get back, and is going to find a way to get there the next time he or she has a visit with me, right? Well, housing becomes, if you worry about effective transitions across the various silos of healthcare, housing becomes important. Any occupational therapists in the audience? Mesa, any occupational therapists in the audience? If you don't worry about the environment to which you are going to send your patient. Such simple things as, are there slip rugs on the floors? Is there a ramp so that you can, in fact, with walker or with wheelchair, get up to the first floor? How wide are the doors within the home? All this stuff becomes important. It's housing, but it is housing that might spell either success in terms of keeping that patient healthy in his or her environment of their own choice, or institutionalization. Institutionalization, by the way, is not a healthy thing to do. Many people would argue, in terms of hospitals, for example, that the worst thing you can do to a geriatric patient is admit them to a hospital. And no matter what they had when they went in, they're going to be sicker when they come out. And by the way, the data show that to be true. Levels of dependency are on average higher when a senior leaves a hospital than when a senior was admitted to the hospital. The current medical system, and if my colleague Janet Head were willing to give me the time, I'd love to get into dialogue here, but I can't. I'm on a tight schedule. My honorarium is in inverse proportion to the amount of time I spend here with you. I've also been told as a member of the board it makes no difference because it's got to be redonated back to the university. And Mr. President, if I do that, can we at least get it into the aging program? That's a decision you as my employee can make? We can make it. Great. Did you hear that, Janet? Okay, it goes into aging. If it's going to go back into aging, let's make that 20,000, 30,000, whatever you think you can get away with. Unfortunately, you're working in a university which has probably the best chief financial officer in the world, Monty Harrison, so you won't get away with it, but push it. Single event focus, that's what, and anyone who wants to disagree, please feel free. We can't get involved in a lot of dialogue, but I'd love to know where I'm kind of going off the reservation. It's fee for service, high technology, a medical orientation, and an emphasis on cure rather than managing chronic conditions. I had an interesting discussion with my class last night where I said instead of giving them the module I had prepared for last night's class, I tried them as a test audience for this speech. They are really disrespectful students at Johns Hopkins, and I don't know why we don't get rid of all of them except they pay a lot of the bills. But we were chatting about why there are so few geriatricians in this country. Why are there so few geriatricians? Let me try this out on you. One of them is money. I mean, geriatricians are dependent to 99% on the Medicare program, okay? You graduate from medical school, and I don't want to get any of you upset about something you already know. You're going to have a little bit of debt when you're done, maybe a lot of debt. And so you've got to look at what reimbursement you're going to achieve over a lifetime, and when you're stuck with Medicare reimbursement, you got a problem. But here's my theory. Is it possible that also the philosophy of American medicine emphasizes improvement, cure, a better status? You're not going to get a lot of that when you're dealing with geriatric patients. You're going to try to ameliorate the increasing frailty, the increasing level of dependence. You're not shooting for the cure. You're not shooting for the silver bullet. I'm not saying that's bad about American medicine. I don't think American medicine would be as world-renowned as it is if it didn't have those people constantly pushing the envelope. But we also need those people who recognize that that's not what the geriatric patient needs. The geriatric patient needs somebody to hold their hand while they descend. Is that a fair statement? No. Okay, I want to see you in the corridor with your lunch. I think that's it, and there hasn't been any research done on this. Whoever it is said no might be just as right as I am suggesting it could be a yes. But it's worth looking into. Here's something you can't really dispute. In American medicine, you get not what you need, you get what will be paid for. Does anyone disagree with that?
No.
Michael, did you disagree with me?
No, I agree with you.
Oh, thank you. Scared me half to death there. Even though the elderly are the only population group with universal health coverage, income determines access because health care is not just health care. The majority of our medical expenses for seniors are Medicare, but Medicare has itself emphasized acute interventions. Did you know that until a few years ago, a preliminary assessment was not paid for under Medicare? Well, how the hell do you put together a care plan for a senior if you're not going to assess the senior? And if the government's not going to pay for it, the senior ain't going to get it done. When did we have drugs? Just what, 5 years ago, Part D came into place? Here's my argument. 5? What happened to the 10 I was going to get? Oh, it was 10, okay. Here's my description of Medicare. A program designed for the 85-year-old woman, designed by the 45-year-old man, who was at the same time a member of both the AMA and the American Hospital Association. Very much a political program driven by financing. I've been told now by my timekeeper, my warden, that I have a limited amount of time, and so I want to move to what I think, this is another good example. You can't go into a nursing facility under Medicare unless you've been in a hospital for 3 days first. Tell me why? It's an accident of history when the skilled nursing benefit used to in fact be called the extended care benefit. In other words, people realized you couldn't just leave the hospital and go home. You had to extend your care. But that tradition continued regardless of whether it was still needed. And I don't know, is this all on the webs or something for people can have access to it? Because I want to get to, and we've talked a little bit about that, I want to get to what we need to do to in fact put together a program that truly works. And I think that program has got to look at the entire patient, not just the disease or the organ. How many of you in a hospital have heard the professional staff, well-meaning professional staff, refer to the kidney in room 425, or refer to the hip transplant in room 310? Not to Mrs. Jones in 425, or not to Mr. Smith in 310. There is a focus in too many cases on the organ and not on the whole individual. How much time do we spend looking to levels of consumer satisfaction? And a critical part of quality management, but one overlooked. We need, as a geriatric model, we need to be interdisciplinary, including all of these aspects. But we need to be more than just multidisciplinary, that is, having all of these. We need to be truly interdisciplinary. We've got to work with each other. We have got to concentrate and focus on the concept of team. One of the most exciting programs in the field of hospital renewal is called the ACE program, Acute Care for the Elderly, where individual physicians, nurses don't take care of the patient, the team takes care of the patient. They meet in the morning, all of them. The pharmacologist talks to the physician, talks to the physical therapist, talks to the occupational therapist, and they develop that plan of care for that patient, for the entire patient, for all the patient's needs. They are truly not just multidisciplinary, but interdisciplinary. How far are we from that goal? We got a ways to go. We got a ways to go even in teaching people about geriatric medicine. 2 geriatricians for every 10,000 elderly Americans. Less than 1% of medical graduates are certified geriatricians. Only 11 out of 125 schools of medicine even require a course in geriatric care. Whereas in Britain, every school has a department, and the specialty is the 3rd largest specialty in the country. Now, different cultures, different environments, can't necessarily make comparisons, but it's worth thinking about. Because, again, to get back to the beginning of this lecture, geriatrics is more than a discipline. It is a reflection of the entire patient. And again, I will emphasize, and I say this not to pander. Although I was a lobbyist for a good part of my life, I know pandering better than anyone. But it's tougher to pander to bright medical students than it is to senators. We have got to worry about what's important to the senior: functional ability, independence, quality of life. And what you will find, and this is fascinating to me, is that the customer can be either the patient or the individual in the bed or the person receiving service, or the customer can, more often than not, be the daughter, okay? They'll have different goals. The daughter is more interested in pure safety. Make sure mom doesn't fall. Mom doesn't really worry about safety. Mom wants to make sure that she can go to bingo. And if she falls in the way, she'll be unhappy, but that's not what drives her. We are talking about a system of care which has both structural as well as operational prerequisites. And the structural prerequisites are you've got to integrate management, nursing's got to work with physicians, it's got to work with therapies, got to work with pharmacology. You've got to have common procedures that everybody adheres to. You've got to have interdisciplinary teams. You've got to work together as healthcare professionals. If you are going to be dealing with the totality of the patient, with his or her multiple needs, be they physical, be they mental, be they medical, be they psychological, you've got to be able to deal with them as a team. And you've got to have financial incentives. There are functional prerequisites as well. Customer focus. It's a buzzword, Quality management, customer focus. How much of American medicine is truly customer focused? Very little of it, quite frankly. And more of American medicine and hospitals and others are beginning to recognize that. My hospital has got major programs ongoing to make it customer focused. Some of them work, some of them don't. We talked about interdisciplinary, assessment driven. How can you put together a plan of care if you haven't assessed the patient first? People do that. I hate to say it about the industry I represented for 15 years, but the nursing home industry had to have Congress tell it had to do an assessment, and it told it what was in the assessment. We now have about a 4-hour assessment process because we let the bureaucrats take over, but the bureaucrats wouldn't have taken over if the industry had done what it should have done. Medical and pharmacy review. Let me give you, by the way, one example, if I've got another minute or two, of why this interdisciplinary approach is so important. Oh, and by the way, don't we have this yet? We've been working on this one, portable electronic records. We've been working on that since I first started in government 40 years ago. I would assume we're there already, aren't we? Anyone else here from Johns Hopkins? Johns Hopkins has 4 hospitals. Main downtown hospital. You see that little dome there? That's the main hospital. We have one where I work, Bayview. We have one in the county in which I live, Howard County General, and we have one close to the National Institutes of Health called Suburban. They all have electronic health records, none of which can talk to each other. So here I am a patient, and I've had some incidents over the last couple of years. I've been in literally all 3 out of the 4, and each time my attending says, "Could you get your records for us?" And I say, "Why don't you push the button?" "Well, it doesn't work that easily here at Hopkins." Or as somebody once said, "Hopkins, we know all about electronic health records. We got 250 of them. We're experienced." A colleague of mine at Hopkins wrote an article, appeared in JAMA, 4 or 5 years ago now. And she developed a hypothetical patient, okay? Was 78, 79 years old. She had the traditional 6 or 7 different diseases that the average senior patient might have. She then had the hypothetical doc apply treatment protocols for each of these diseases. And these were not just protocols, these were scientifically driven clinical practice standards. Exactly what you're supposed to do for the diabetes, for the stroke recovery, for this, for that. And guess what the end result is? You kill the patient. Literally, because there are so many counterindications in what has to be done. So you've got to have different disciplines talking to each other. And forget the rest of it, like social and housing and transportation, even in medicine. You have got a patient who presents on average 5, 6, 7 diseases. In terms of polypharmacy, is consuming 7 or 8 different drugs, and yet people don't focus on that. That was quick. That's the end of my remarks, folks. That's why there's nothing up on that slide. But I'm going to take some questions until my mother says I can't take any more questions. Dr. Slocum.
Thank you, Dr. Willging. It was an excellent talk. I hear a rumor, and I just want to know if this is indeed factual, that we actually have fewer certified geriatricians now than we did 10 years ago.
Unfortunately, that is true. We had 10 years ago 12 to 13,000 certified geriatricians. We now have 7 or 8,000. For a simple right reason, back when they started certification for geriatricians, they grandfathered in any internist who said he or she practiced geriatrics. And inevitably, the time comes where you've got to re-up. And the internists, on average, were saying, well, wait a minute, I'm going to re-up for internal medicine, but I don't really need to re-up and pay the money and do whatever it is you have to do. So yes, we have dropped dramatically. And it's a shame, but I have a solution for that. Hopefully the potential physicians and the actual physicians in the audience will accept me for that. I like to think of, what's the term I'm going to use instead of team leader, Janet?
Shared leadership.
Shared leadership. We in pediatrics recognize the value of healthcare professionals who are not necessarily licensed physicians. We call them nurses. And we have a specialty called pediatric nurse practitioner. We actually have a specialty that is totally underutilized called geriatric nurse practitioner. I think just as is the case with the pediatrician, where not every case that walks in the front door needs to be seen by the pediatrician. The same holds true in geriatrics, to a lesser degree. The complexity of what passes through the geriatrician's office is probably much more overwhelming than the complexity of events that pass through the pediatrician's office. But I think we have not yet recognized that within this concept of shared leadership, the advanced clinical practice nurse can do an incredible job of lifting the burden from the decreasing supply of geriatricians. That doesn't stop me from wanting A.T. Still University to start generating about 10 to 20 certified geriatricians every year. I want you to take over from Hopkins, because Hopkins doesn't have the Still philosophy. By Still, I mean the founder of our university, of mind, body, spirit. Those are a bunch of allopaths, organ-focused. If this gets back, by the way, to my colleagues, I will have to deny it, and I will have to call Luigi in terms of somebody's kneecaps. Other questions? Yes? There are no programs different than what we've had for all medical students, except, there's always an except, I have not yet read the appropriate pages out of the 1,700 that just got passed in health reform, but I've been led to believe that there are in fact special programs to emphasize both the further development of internists and primary care physicians, as well as with a special emphasis on geriatrics. I've got to look at that and find out exactly what they're willing to do. I hope something good, but having spent so much of my career in public policy, I know there is no idea so good that the government can't ultimately screw it up. So, yes?
You mentioned that there's a greater emphasis in England as far as geriatric care. Is there a difference in quality of life stats or age stats, age of like how far you're getting to live? Dr. Willging, can you repeat the question?
I can repeat the question, that there appears to be a greater love of geriatric medicine in England than there is here, but what are the outcomes? Do you see a difference in terms of quality of life or other kinds of outcomes? Is that the question? The answer is we don't know. It depends also on whether you are a Republican or a Democrat, because the Republicans would argue that that is a national healthcare system and it can't be as good as the system we have. The data don't show a change. In fact, depending upon what data you look at, and there is that old saying, you know, statisticians and statistics don't lie, it's the people who interpret the statistics. I was chatting with somebody from Canada in my class just last night who said, you know, yeah, you hear the stories about people traipsing across the bridge from Windsor, Canada to get their care in wherever, Detroit, heaven forbid. I didn't say that, did I? But there is not overwhelming or even persuasive data on either side, because the people getting their care, you know, seem reasonably satisfied. I got my care in Germany, which is a different system altogether, for a number of years when I studied there. didn't find myself either better off or worse off than in terms of the care I got in the United States. Now again, I was reasonably young then, not a geriatric patient.
That was a gentle hint, is the question.
Wasn't very gentle.
But I didn't do it. Did you need to finish answering that?
No, I'm
Okay,
fine.
all right.
It's good to be home, folks.
All right.